A warm good evening, everyone. Thank you so much for joining in. It's a wonderful Sunday again. We're back with the second episode of the International E-CONCLAVE on oral cancer. Today, this year's theme is capacity building for oral cancer. And now we move ahead to our scientific sessions.
We would now move on to the scientific session fourth for today's day. And the chairperson, as you've just met, Dr. Shamit Chopra. He is the attending and chair, Department of Head and Neck Surgery, Patel Hospital, Jalandhar. He is also a member of the board of directors, Patel Hospital. He is also a member of the executive committee of the FHNO, the Foundation for Head and Neck Oncology. He is the member of the National Fellowship Task Force, FHNO, the Association of Oral and Maxillofacial Surgeon. He'll be chairing this session. And as for the speaker, he is Dr. Abhishek Mahajan. He's a consultant in the UK. He's done his fellowship in cancer imaging from London. And he's a consultant radiologist in Clatterbridge Cancer Center, NHS Foundation Trust. The session that he'll be speaking on is NIRADS, or Neck Imaging Reporting and Acquired Data System. Over to you, Dr. Abhishek.
Thank you, Khyati. And at the outset, I would like to thank Dr. Pavan, Dr. Reena, and Shruti for organizing this and giving me this opportunity. I think the topic was NIRADS and AI. I think I'll start with NIRADS first. So NIRADS, it stands for Neck Imaging Reporting and Database System, which is now the means to report imaging in the head neck cancers, and one should apply in the post-treatment setting as soon as possible to standardize your reporting in the post-treatment setting. So post-treatment surveillance has always been a challenge for both the clinician and the radiologist, and then there has been significant discrepancies in terms of which is the right modality to use. It's very subjective in terms of reporting, and also there has been variable data in terms of how the imaging reporting has been done, the accuracy, diagnostic accuracies, and the outcomes. So various guidelines exist for post-treatment guideline surveillance. NCCN says that if there are no symptoms, the first imaging can be done post 6 months of the therapy. However, with the implementation of NIRADS from 2016, there has been significant standardization and the communication between the radiologist and the treating physician as to how the reporting is done and what is the challenges which are faced during the reporting and what should be the clinical implication of this NIRADS reporting database system. So the surveillance algorithm which we follow here a bit different from now what I used to follow back home. We do a PET and CT at 6 months, and if it is negative, then we follow up with CT neck and chest, and if it's negative, then CT neck again, and then we do a routine follow-up at 12 months, that is 1 year. However, NCCN says that if you are using a tool as a CT or a PET CT at the end of treatment, it should be done at 3 to 4 months. But if CTRT is used as a curative intent, then imaging at 4 to 6 weeks would be ideal imaging, 4 to 8 weeks. But I, in my practice, recommend using at 12 weeks because you can get a better response, incomplete response, if you are clinically suspecting. Then at 4 to 8 weeks is the right time to use PET-CT. In patients who are at high risk of lung cancer or synchronous malignancies of the upper GI tract, have a history of smoking, they should also undergo a chest screening at the time of the CT scan, and it does not add much cost to the routine screening protocol, and it adds benefit into picking the second malignancy early. So previously the criteria was there to do imaging in the head neck post-treatment setting. However, this was very subjective and it was based on the PET modality alone, and they used to use IJV and the liver uptake as a standard tool. So if you had IJV uptake, the uptake in the lesion less than IJV, it was a complete response. If it was between IJV and liver, it was metabolic response. But any focal uptake beyond liver or any focal intense uptake was suggestive of a residual tumor. So this was quite subjective and it was only PET based. What NIRADS did is, NIRADS has included the various lexicon measures where there is definition for non-mass, mass-like enhancement and mucosal abnormality. Mucosal abnormality is the one which you commonly see in your practice, and it is mostly related to radiotherapy, which leads to mucoid density, diffuse enhancement or mucosal enhancement. And nodes are also categorized separately. So there is a separate lexicon for nodes in the primary lesion. The nodes, if there is no residual disease, it will not show any morphological or functional uptake in the disease area. And if there is a growing node, it is taken with a pinch of salt. So NIRADS category range from 0 to 4. The 0 is inconclusive, where you need an additional tool. Let's say you've done an MR or CT at the baseline, and then you are not very sure of what is happening in the local site or the nodal site, then you would call it as NIRADS category 0. But the normal categories which are used into the lexicon are 1 to 4, which is category 1 stating no evidence of tumor. Category 2 is ill-defined, mild, moderate FDG uptake, which is a treatment-related change, and it's clinically evaluated and labeled as category 2. It is further divided into 2A and 2B, which we'll see in the subsequent slides. Category 3 is a very high index of suspicion, where you need to do a biopsy and inform the clinician that this lesion needs a biopsy. Category 4 is definitive recurrence, which is pathological or clinical proven recurrence, and it is or a radiographic progression. And these patients are either managed palliative or with or new treatment modalities such as immunotherapies and so on. So let's look at when you call a category as NIRADS 1, you do a routine follow-up at 6 months, which is routine recommendation as per your guidelines. The NIRADS 2, if it is a mucosal site uptake, which can be seen on direct inspection, then you can do a direct inspection, which is called as NIRADS category 2A. If it is a deep-seated lesion in the high ITF or in the deep submucosal region where you cannot do a clinical examination, it's called as NIRADS category 2B, where you need to do a short interval follow-up with PET. And if there is an uptake, then you would take it as NIRADS category 3 and do a biopsy. So NIRADS category 3 is a strong indicator that there is a recurrence, and this should be biopsied in all cases. NIRADS category is a clinical care of recurrence. So let's look at some cases. The first case is the 35-year-old male who was case of a base of tongue squamous CA T1N2C underwent radical chemoradiotherapy. You can see the primary disease over here. And there was a node which was treated with radical CTRT. The patient had a 3 months, 12 weeks post surveillance PET CT. No uptake is seen, mild mucosal thickening, and this is no abnormal soft tissue, no abnormal FDG uptake. This kind of findings, which are no abnormal soft tissue, no abnormal distortion, mucoid-like intensity in the treated region, or diffuse linear enhancement, these are radiation related. They are called as NIRADS category 1. The NIRADS category is separately labeled for primary and the node, and a routine surveillance is advised. The chances of the negative predictive value for NIRADS category 1 is 94%. The next case is a 43-year-old male diagnosed with base of tongue malignancy. Again, he was a T4A cancer. There was a large disease over here, which was FDG avid, and there was a avid node as well. The surveillance scan at 3 months showed mild mucoid and change in the primary site with focal uptake. This was a discordant finding. So NIRADS category 2 are usually discordant finding. Either there is a FDG uptake with no mucosal abnormality or mucosal abnormality without FDG uptake. So in NIRADS category 2, you see that there is no, in this particular case, no abnormal soft tissue but moderate FDG uptake. This is a NIRADS category 2 because the clinician can do a direct visual examination, and based on the changes in the mucosa, it can be labeled for a close follow-up or a biopsy. So NIRADS category 2 are focal superficial enhancements or focal uptake which are discordant with each other. And the NIRADS category 2, as I said, they are further divided into 2 subcategories. If it is superficial, the patient can undergo a direct inspection. If it is deep, it can require a short interval PET uptake, which is done at PET CT, which is done at 3 months. So remember that discordant finding should always be labeled as NIRADS category 2. The next case is a 28-year-old female, which she was a diagnosed case of maxillary carcinoma of the sinus and underwent resection and chemoradiotherapy. This is the primary tumor, and after resection on follow-up, there was a focal enhancing soft tissue with the bony changes, and it was showing intense FDG uptake, which was quite similar to the brain parenchyma adjacent to it. This patient underwent, so there was a concordant finding with the soft tissue, which was showing intense uptake. And this patient underwent a biopsy, and the biopsy turned out to be a recurrent tumor. And in the NIRADS category 3, you have a concordant finding with the abnormal enhancing soft tissue on the morphological imaging and intense uptake on the PET imaging. So any NIRADS category 3, a recommendation is to do a biopsy, and the positive predictive value for this is approximately 60%. The next case is a 47-year-old female. She was a case of CA tongue, T2N2, underwent surgery for the primary and neck dissection. at 3 months outside the hospital, and she came to follow up at Tata Memorial Hospital. She was 3 months post surgery presented to our hospital for further management. So at the 3 months post therapy, the patient came to the hospital, a baseline imaging was performed to decide on the further management, and no abnormal soft tissue was reported on this. The patient underwent another imaging at 9 months post therapy, which was done with PET-CT, and there was an abnormal nodal soft tissue which was showing intense uptake, which on retrospect was close to the vessel and was marked as abnormal in the previous 3 month scan. This patient underwent a biopsy, and this turned out to be a recurrent tumor, and this was then salvage neck surgery was performed, and this was positive for recurrence. The NIRADS category 4, as seen in this particular case of laryngeal cancer, which was a post-op laryngectomy case where there was a large soft tissue at the stromal site with ulcerative lesion. It was seen in the clinic and was labeled as a recurrence. The PET scan was performed to see whether there was other sites of metastasis. And NIRADS category 3 and 3 or 4 can be performed backwards. These patients usually don't need biopsy, but to label them as palliative, you need to do evidence-based management to categorize them as recurrences if they are smaller recurrences. So NIRADS category 4 is pathologically proven recurrence, or there is definitive clinical progression or definitive recurrence on the single site of the surgery. We have our data from where we had done a retrospective study on a cohort of 800 patients, and we found that a significant correlation with NIRADS reporting in the category 1, which were 100% accuracy, 100% negative and positive value, which dropped down to 70% and close to 70% of the positive value in the NIRADS category 3, with very good results in the NIRADS category 4 as well. The results were better in terms of the nodal cohort, and if you see, the NIRADS category 2 and 3 were performing very well. So if you are labeling node in NIRADS category 2 and 3, this was CT based data, and remember that CT always is a subjective modality, but did perform very well in our cohort. So NIRADS is based on the site of the disease. So primary, if you have NIRADS category 3, you do a surveillance. If it's NIRADS category 2, you do a direct inspection, and it's a 3, then you do a biopsy. And if it's 4, you don't need to do biopsy. You can directly manage the patient accordingly. Similar to the for the nodal site, you have NIRADS category 1, which is routine surveillance. If it is a superficial node, you can do a short interval follow-up or a biopsy of the patient if it's strongly indicated in NIRADS category 3. And if it is definitive nodal increase with the serial imaging or on the biopsy proven, then it's managed accordingly. So not all cases are so simple. Sometimes you find tricky cases, and seen in this particular case, this was a case of adenocarcinoma of the sinus cavity, which underwent surgery, and post-surgery there was no residual disease. It's a flap. You see no uptake in this area. Patient underwent the and post follow-up, you see that there is significant moth-eaten appearance of the bones in the skull base. This patient had an admixture of post-treatment changes with enhancing soft tissue, which was suggestive of osteoradial necrosis with recurrent tumor. So sometimes you find challenging cases where the patient is actually in deep morbid state, and you have to take a decision. Not all cases should be labeled as post-treatment. Sometimes you see admixture of the disease as well. So the take-home message from my NIRADS is practical imaging surveillance template, which is used to guide appropriate imaging interpretation, follow-up, and next clinical management steps. And it helps standardization to link with the management recommendations, correlation with patient outcomes that has potential to validate performance and highlight the radiologist value to the patient care. I'll show a few slides on AI, machine learning, and neural network and deep learning. It's a very new, innovative tool which is still upcoming in the era of head neck cancers, and a lot of work is done in preclinical imaging and also in the assessment of the tissue slides, but a lot is pending in terms of the radiology AI. So AI is actually a computer programmed which is made to think and behave like a human being. But machine learning is a niche area of AI where you tell the machine to do data processing as to being not explicitly told what to do. And when you do any machine learning algorithm, you use something called as neural networks. These are the backbone of any machine learning algorithms. They are similar to human neurons, and deep learning is the algorithm which you use to do a machine learning. So neural networks are basically like a neuron. You give an input signal. There are hidden layers which is similar to the brain processing unit, which process these signals and give an output. So there is an input signal. There is activation of threshold. There's input from the each dendrite which is summated and then generates the output signal. So how a human brain thinks looking at an apple, it processes the image into multiple subsets, being the color, the shape, and the texture, and it processes the fruit as an apple. Similarly, an apple is presented to a neural network which is broken down into multiple pixels, which these pixels are read as color, shape, texture, and other features, and they are read by the computer algorithm as an apple. So machine learning is of three types. What commonly used in medicine is the supervised and the unsupervised learning. The reinforced is the one which is used in the AI, in the trafficking, which is the motor trafficking. So what is supervised learning? In the supervised learning, you have an input data, a training, and an output data. The data is labeled. Any kind of data which is labeled, that means you tell whether it is a benign or malignant disease a priori. That kind of labeled data is called as a supervised learning. So let's look at an example. The data is split into two parts, training and the test data set. The training model is labeled data set from where you do the deep learning algorithms. Once the deep learning algorithms are done, they are evaluated on the test data set, and this is used for clinical evaluation. In an unsupervised learning, you do not label a data set. The data set is automatically divided into groups by the deep learning algorithms into various subgroups. And this is much more better way because it removes the bias. But however, if the data is too heterogeneous, that may lead to underperformance of the algorithms. So let's look at these four set of coins. They are different in color. This is being processed by the algorithm and they have been divided into various groups, something similar to stages of the cancer. The computer understands there is a red color, there is a gray color, and there is a blue and a yellow color. This kind of learning is unsupervised machine learning. So in radiology, we use a radiomics cycle to do a deep learning algorithm. You do image acquisition, you do segmentation of the imaging, then you do feature extraction and you do analysis. I'll give an example from what is published by our group. In the lung, you do acquire the images, you do segmentation of the images, you do extraction of the features, and then you do the selection and analysis with outcomes. So artificial intelligence used by any kind of machine learning algorithm can be applied to diagnosis, can be applied to treatment, and can be applied to prognosis. We've had several publications in this era by my group where we've used AI in lung, brain, and other areas to even predict gene mutations and do segmentation and outcome analysis. And I'll end my AI talk with that, with a SWOT analysis, that the strengths in India for AI is availability of big data, emerging talent pool, and availability of qualified professionals. However, the weakness is that there's inadequate source allocation. There's very little awareness and acceptability and standardization of data set. Standardization of data set is a very important area where we need to concentrate before applying any AI tool. The opportunities in India are the public and the private partnerships, the national and international collaborations. The threats, which I do not feel any threat it is, there's no job redundancy. However, people do talk about job redundancy. The biggest threats in this particular era is the legal and the ethical issues. Many of us are using the patient-related data without taking any approvals from the institutional boards, and data privacy issues are one which are going to be the challenging issues in the AI applications. So with that, I thank you for your kind hearing, and any questions, I'll be happy to take. Over to you, Shamit.
Great talk, Abhishek. I think you can see the comments in the chat box. I think everyone is united in appreciating the conciseness, still giving the information that you're able to give. Before we turn on to questions, I will ask you something about NIRADS. You work at an Apex Cancer Center and you continue to work at another Apex Cancer Center. How challenging is the incorporation in a multidisciplinary setting? We all know that we went through that phase in NIRADS and Bethesda and everything, and now everyone has standardized approach that. Is NIRADS particularly applicable in the neck where you showed better data, especially for NIRADS 2 and 3? More accuracy, acceptability, and how's your experience been? Just a minute of that, please.
So before NIRADS, we used to randomly report cases. There was a lot of heterogeneity in reporting with inter-reader. Sometimes you might get your own report and you read it again, and you're not actually going to categorize into one category. So NIRADS give a level of confidence to a radiologist to put in a category. With this category, you are sending across a message to the clinical oncologist who's going to treat this patient. So with these standard linked recommendations, you can actually manage the patient better. It's a very simple tool, not much of things applicable. We have our NIRADS template on the website, which will be coming as a publication soon. So you can use this template, which is modified to Indian subcontinent, where CT and MR are the primarily used tools, and we have also made similar templates for per primum cases also. So I think synoptic reporting and any kind of linked data recommendation guidelines such as BIRADS, TIRADS, and others, they improve the diagnostic accuracy and also the outcomes. Randomly reporting cases can be challenging, I feel.
Totally agree. And I'm sure after this talk, a lot of us will go back to our radiologists and nuclear medicine physicians asking them to adopt this. Have you found it more applicable in MR versus PET? And is there a particular timeline where you have found the NIRADS to be more representative compared to a different one? I know you mentioned the 6-month timeline. All of us follow the 3 months. Just your thoughts on that.
So the basic challenge which we face in our hospital is because you are very sure of the treatment protocols in your hospital, it's easy to apply there. But if the patient is managed outside and the patient comes to you and you are not very sure of the kind of surgery and treatment the patient has got, it becomes challenging. So in our hospital, we don't have a very routine protocol of doing PET CT in all the patients. So they used to be managed, imaged accordingly. Like if there was a larynx cancer treated with CT-RT, we would do a PET CT, then followed up with CT. And if it was a tongue cancer, we would do a MRI. So our data on NIRADS was based on the routine protocols which are used in Indian subsetting. PET is not a strong recommendation, but the challenge is only if you sit with your clinicians on the MDTs, you can actually get to know what the clinician is seeing and what you are actually seeing on the images. I think it needs a bit of a training by the MDT meetings, and once that is done, the radiologist will be very confident in applying this.
Again, great speaking and well chosen topic by the organizers. That's it from me, and over to Khyati and Shruti and Pawan.
Thank you, Shamit. Thank you, everyone.
Thank you, Dr. Shamit. Thank you, Dr. Abhishek. Definitely, you've given a great idea about NIRADS, and now everybody knows about it, and I hope we can soon incorporate it in our system as well. Dr. Pawan, let's do something about this as well. Thank you, and I give it over to Shruti.
Thank you so much, Dr. Khyati, and thank you so much, Abhishek ji and Shamit sir, for a wonderful summation on NIRADS. I think it's a beautiful, all sessions were absolutely fantastic. We come to the end of technical sessions.